This week on the BackTable Podcast.
I think in practice, what makes sense for operators who are, fresh graduates is there's no harm in pairing up with somebody else. Having a second pair of hands and a second head there with you helps, because it's not just going through the motions and the steps, but it's, somebody who's there that can troubleshoot and can help you when you are unable to recross, for example, or you recross but you're unable to deliver a balloon to the side branch now. And so something like that. And I strongly advise that if the volume is about 50 a year, then early career operators really should be pairing up, and it'll give them the experience that they need.
Hey everyone, welcome to BackTable Cardiology Show. I'm your host, Dr. Sameh Sayfo, Interventional Cardiologist from Baylor's Cardiology Heart Hospital, Plano in Dallas, Texas. I'm very honored to have a colleague and a friend, Dr. Mirvat Alasnag, coming to us from Saudi Arabia. She is the Director of Research in Cardiac Catheterization Lab at King Fahd Armed Force in Jeddah, Saudi Arabia. She is also a SCI Interventional Committee Chair. She's in charge of the TCT plus Middle East Conference. She's very involved in many of the international societies, playing a major role. And also she's the chairwoman of the Cardiovascular Research Consortium of the Middle East and an advocate for women in interventional cardiology and many, many other roles in research, clinical, and advocacy. Mirvat, we're honored to have you today. Welcome to the show.
Well, thank you very much for having me. I'm excited to be with you and everybody in Texas.
Well, today we're going to be talking about some interesting topic. It's more of the clinical aspect of it. Maybe we'll talk about research. It's the bifurcation coronary intervention. I think this is a part of a day-to-day practice we have to deal with. Can this start for our audience will be ranging from medical students, cardiologists, interventional cardiologists, cardiology fellows, different level of expertise. Why don't we start, when you hear the word bifurcation coronary intervention, what comes to your mind?
Well, what comes to mind is preparation. I think these are the kind of lesions that I don't like to do ad hoc. These are the ones that I want to study carefully, the films, the angiograms, the condition of the patient, what the risk factors are. Will they tolerate long-term dual antiplatelet therapy? But I also have learned over the course of the years to try to be minimalistic. So my default strategy is, in fact, a provisional strategy for the majority of bifurcations. And so part of the planning for these patients, these procedures, even though I do want to resort to a provisional strategy or a stepwise provisional strategy, we always have to have a plan B or an exit plan. So if a provisional is not enough and we do need to go to a 2-stent strategy, I need to have planned it well in advance. So I'm not thinking on my feet mid-procedure like, oh, I'm losing the branch, so what's next? And usually when you're studying very carefully the bifurcation itself, you're looking at the side branch. Does it have osteal disease that's significant or not? Does it have a tight angle or an acute angle? Is the vessel itself, the side branch, long and significant, or is it a small side branch? Based on a lot of these factors, you decide on what your bailout strategy is going to be, and not just whether you want to start out with an upfront 2-stent strategy.
Let's start basics. What are the different strategy that possibly you can choose from? And let's just basically start generalize, and maybe we can go one by one.
So probably the one that is most commonly used is the TAP technique, and that's the 2-stent strategies. I'm going to start with those. The TAP technique is probably the one that's used most, primarily because it is easier, although a lot of the data show that some of the other techniques, culotte and DK crush, have better outcomes with fewer event rates. And I'm not sure if the data is a little biased, the evidence is a little biased, primarily because a lot of the trials that were done for TAP were done where TAP was a bailout technique rather than an upfront strategy. So that may have impacted the results of those trials. But it does have fewer steps. And so for beginners, it is an easier procedure to do. But in my experience, when patients do come back later, the one that is probably more difficult to handle is the TAP, because you have a neocarina and you have to be very careful not to touch that. So the TAP technique is you deploy a stent in the main vessel, and then you put a second stent in the side branch that is probably closer to a 90-degree. The other two stent strategies are the DK crush, where you deploy the side branch stent first, and we usually resort to that when the side branch is sizable and has a significant lesion, that you're concerned that if you start stenting the main vessel, you lose the side branch, particularly if the side branch wiring and access is difficult. The DK crush is, a lot of the data that was done was actually done in Asia. The technique itself has been refined from a crush technique, mini crush, DK crush, and so on. The culotte is, again, a two-stent technique where there's more protrusion into the left main. It sort of mimics a trousers kind of technique. It's done a lot more frequently in Europe. The only thing is with DK crush, you're going with an upfront stent in the side branch, and so it's not really a bailout technique. So it's not a technique that you will use in a provisional strategy. It's a technique that you will use when you've made up your mind that you're gonna start with an upfront two-stent technique.
So Mirvat, what I understand from what you just said is that if you're thinking this is going to be a two-stent strategy, it is better to start your case with a two-stent strategy, no matter what this two-stent strategy is, comparing to bailout. Am I hearing you correctly?
Yes, that is what I'm saying. So if we find a true bifurcation and we have determined that the side branch is significant and sizable, then an upfront two-stent strategy is probably wise. And, depending on the expertise of the operator and the anatomy of the bifurcation, we can either opt for a DK crush, a culotte, or a TAP technique. Those are the two-stent strategies that we often use.
These studies, the research studies that have been tackling this question started in 2008, early on with the Cactus trial, and then we had the BBC one. But really, the last few trials that really made an impact on practice is the DK Crush 5, the EBC main, the Definition 2, and recently the BBK2. And the problem with what we have in most of cardiology section is the different trials sometimes conflicting with each other. So how do you implement, for example, EBC main in your own practice? How do you recommend for people to look at this trial and choose which trial to take?
So this is a really good question. The thing is, EBC main and DK Crush 5 are very different trials. Not only because geographically one was conducted in Europe and one was conducted in, Asia, Korea, but really the complexity of the syntax score of the bifurcation, the side branch involvement was a lot more significant in the DK crush. So in real practice, if I have a patient with an anatomy that is more aligned with those that were enrolled in EBC5, those are the kind of patients that I would likely go with a provisional strategy only. DK Crush 5 is, for more complex lesions. Clearly, that was one of the main differences. But I think both trials, something that was very important for us to understand is that the recruiting centers, they really had a minimum number of procedures and volume for the operators. So these were expert operators, whether they were in Europe or whether they were in Asia. And I think one of the concerns that I have is that I'm seeing fresh graduates with little experience are jumping to a two-stent strategy more frequently than they should be.
That's exactly why I asked this question. I see it, we're a busy hospital for us, and I see it in our hospital, another hospital, where the new graduate, they go for the two-stent strategy more often than provisional. And maybe those are with the trial, and maybe that comes with experience. Two-stent strategy will require more time. And definitely, in the US, we're not as lucky as Europe and the rest of the world. You do not have a DCB de novo for de novo lesion. So if someone want to do a provisional, you have experience with the DCB and de novo lesions. If someone in the United States, let's say 5 years from now when we have it available, do you think that available DCB will change our practice to be more provisional because we're DCBing the branch? How do you implement it? What do you recommend to the new graduate?
So, I do think we're going to learn a lot more about drug-coated balloons. I do think these are transformative technologies. The main reason that or stents in general were developed was abrupt vessel closure after balloon angioplasty. But balloon angioplasty, plain old balloon angioplasty, really re-established flow in the vessels and was fine. The main caveat or the Achilles heel of balloon angioplasty was the abrupt vessel closure from dissections. But I think as we learn more about, plaque selection and about plaque modification and which dissections we can safely leave behind without an increase in, event rates later, we're going to start getting more comfortable using drug-coated balloons in bifurcation. So, in our center, we started it. We published a series of about 50 cases where we did the side branch with drug-coated balloons alone, and then we brought these patients back and re-evaluated them non-invasively with a CT. And more recently, there was a large randomized trial that was presented, the DCB bifurcation trial that again was done in Asia, that actually showed that it was very safe to use drug-coated balloons for these bifurcations. I think they do simplify it. Again, it does treat the lesion, but there will be those lesions that we're going to need more trials and more studies to look at. For example, a left main and a circumflex, a dominant circumflex. Am I going to be comfortable leaving that with just balloon, even if it's a drug-coated balloon, or am I going to want to put a stent? I'm sure as more data comes, particularly imaging data, intracoronary imaging data, it's just around the corner. And I believe in another 12 months, we're going to have a lot of core lab data coming out of the drug-coated balloon trials that's going to teach us a lot more about, which dissections you can walk away from and leave behind safely and so on.
DCB in bifurcation, we had a recent conversation with our colleagues in Europe, and they kind of blew my mind that the way they practice it, and I want to hear your input, and is that how you recommend it, is that they DCB the branch first, and then they put a main vessel stent, and that's it. Is that what you recommend doing it?
Yeah, because once you put in the stent in the main vessel, you don't want to disrupt it by any means. So I don't want to be passing drug-coated balloons into the side branch and inflating them and so on. For a reason is that when we look at some of the bench models, when we were testing some of these, not just drug-coated balloons, but balloons in general, when you're putting a balloon in the side branch, what you do end up doing is lifting and interrupting the stent struts that are in the contralateral wall of the main vessel. So there's potential for you to damage it unless you're doing kissing inflation. So you end up doing more steps. So if you end up ballooning first to the side, first pre-treating your main vessel and doing all the plaque modification that you need, then pre-treat your side branch with the drug-coated balloon, and then you're out. Then you start treating the stent in the main vessel. There's less chance that you're causing any kind of disruption in the main vessel.
Excellent. And you pointed out, you mentioned something briefly, the importance of imaging in those kind of cases, and recently the IVUS in complex PCI is class 1 indication at the European Society of Cardiology, and you actually you presented that during their updated late breaking studies and late guidelines. Can you comment about that? What imaging, how often they need to image? Does it really matter what type of imaging? What's your input on this one?
So Sam, I'm really glad you brought that up. Intracoronary imaging, whether it's optical coherence tomography or intravascular ultrasound, the idea is that we want to be optimizing the PCI, optimizing our stenting technique. And it isn't just that we want to pass a probe down or a catheter down and say, well, I imaged. Whatever information we get from that imaging catheter needs to be actionable. So if my stent is underexpanded, if there's an edge dissection, if there's malapposition, I need to go back and fix it. So there's a lot of trials now that have come out. The October trial looked at, bifurcations and complex lesions and using OCT in those. Of course, it was a little cumbersome, quite a few steps. But what I would say is at bare minimum, pre-procedure, pre-stenting, you do a baseline imaging, whether it's IVUS or OCT, whatever your lab carries, and whatever you're more comfortable with in interpretation and image acquisition. And you want to get your stent length, reference diameters, select your landing zones, instead of just eyeballing and making a guess. And the other thing is really determining whether your plaque is calcified, it needs treatment, modification, and so on. You have the option of, assessing after you do, for example, atherectomy or lithotripsy or what have you, putting in a catheter and assessing whether you've done adequate plaque modification, and then putting in the stent. If you want to skip that step, I don't advise it, but at least at bare minimum after stenting, you do need post-PCI, and then you start looking at the apposition and expansion of the stent itself and looking at the edges and making sure there are no dissections and that you're in a near normal landing zone, and, fixing if you do find that you have even small areas of malapposition, going back in there and trying to get your stent better aligned and better apposed.
Yeah, I mean, the IVUS trials and data is showing not only, it's showing also mortality benefits, reintervention benefit. Not uncommon for people to miss ostial, branches or edge dissection or landing in more than 50% lesion. I think IVUS is growing, and the good thing is that new graduates in the United States, and I think also in Europe, is part of their training, part of the practice. It's so hard to convince someone who's been doing it for 20 years one way to change it, but hopefully we're having more and more graduate. You graduated from Loma Linda, and then you never practiced in the US. You moved and practiced in Saudi right away, correct?
Yeah, so I went to Michigan, did a year of complex PCI, interventional year, and then went back to Saudi Arabia and started practicing there.
So, coming to Loma Linda training, coming to Detroit, getting an extra complex coronary. It's the United States, there's a lot of technology in the US, but we're still behind on a lot of other technologies. How hard it was, and then you're busy internationally, you go to Asia, to Europe. How do you think from a bifurcation intervention, what's different between US, Europe, and Asia? And you've been through all of them.
So the US are a lot more conservative about using intracoronary imaging. They're very liberal about using mechanical circulatory support for high-risk PCI. And I see almost all left mains are being done with mechanical support, so Impella-supported microaxial pumps. You go to Asia, it's probably the other extreme. Almost every PCI, whether it's a bifurcation or not, is done with IVUS. So over 90-95% of their procedures are done with imaging. And they almost don't use any mechanical support. Europe, they don't use as much imaging, but they again also don't use a lot of support, particularly in the United Kingdom. I like to find the middle ground. I am picking up a lot in my practice of imaging, and particularly with complex lesions. But with time, I've learned that not every left main needs an MCS. And I think it is important to recognize that it's not just about them being expensive, but they do come with complications to the patient, vascular complications, bleeding complications, and so on. And recently, the EAPCI elaborated a document on high-risk PCI where we do comment on mechanical support and when to use it. And the anatomy is one part of it, but we can't forget that the patient presentation is another part of it. So if their AEP is high, if their ejection fraction is low, if they have concomitant valvular heart disease, these are all factors that will make us think again and again about using mechanical support. If you're the last remaining vessel, if you're going to need atherectomy and rotablation or something like that, these patients don't have reserve, and you will need some kind of support. So it's just really creating algorithms and figuring out with your algorithm who are the patients that need upfront support, who are the ones where you're just going to get access in the groin just to be safe in case you need it, and who are the ones that you can just go ahead and do your PCI safely without subjecting your patient to an MCS. So I think there are a lot of factors to look at. Another important factor is dual antiplatelet therapy. I'm more inclined to, use a provisional strategy with drug-coated balloons and so on in someone who can't have protracted DAPT. So I try to keep it as simple as possible if I know my patient is at high bleeding risk.
And do you believe that maybe from a, society, social reasons or beliefs where maybe with Asia, there's more experience with bifurcation across, for example, Japan, where CABG is not as recommended comparing to the United States, where still left main bifurcation, it's CABG till patient is not a surgical patient. Do you think that play a role? And also, what about patient size? Does that really play any role in bifurcation intervention?
Yeah, I mean, the thing is, it's interesting. When I was training in the US, I would never imagine putting in an LAD, a proximal LAD, anything smaller than a 3.0 stent. But you come to our part of the world and people are tiny. They are small. So it isn't uncommon, and I'm getting bolder with intracoronary imaging to use bigger stents as much as I can, but they are small. And the thing is, people are afraid of surgery. We have some very good surgeons that do minimally invasive procedures and so on. And I see it even with TAVR, whether it's in the US or other parts of the world, as they're gaining more traction, not just by operators, patients, younger and younger patients come and you try to explain to them that it's a lifetime management, that you're young, you should be able to tolerate a surgical AVR. But a lot of them come, even though they're young, that they want a percutaneous procedure. They don't want the long recovery. They are afraid of the GA and a cracked chest and so on. So I think these are conversations that for bifurcations, we need to have very carefully with our patients. So if a patient is a surgical candidate, we need to talk to them and tell them you're young or you're diabetic or you have LV dysfunction. You will do better with CABG to get a more complete revascularization. The caveat with PCI is that, I'm treating, for example, a big bifurcation, like a left main bifurcation, but leaving everything else behind. And so you end up with some kind of a residual syntax score, and those patients that have incomplete revascularization have worse survival in the long term.
What's your recommendation on patients who receive a bifurcation intervention, provisional versus 2 stents, in terms of post-intervention depth, the length of depth, and also how do you follow up those patients? What testing would you do and you recommend?
So the follow-up is clinical, really. So unless they have symptoms or anything that prompts a relook angiogram, we don't simply do it routinely. In terms of DAPT, I like to have these conversations up front with the patients before the PCI to kind of let them know that for complex PCIs, I would like, particularly if the patient came with an acute coronary syndrome, to go for a longer duration, approximately 6 months to 1 year. Only if they're high bleeding risk, or if this was not an ACS, more of a CCS type of patient, those are the ones that I would go for an abbreviated regimen. So 1 month of dual antiplatelet, and then I can convert them to single antiplatelet. Having said that, the master DAPT trial actually looked at these patients, and our center was one of the centers that was recruiting in the master DAPT, and we did do a lot of complex lesions in those patients who had high bleeding risk, and a very abbreviated DAPT did well in that trial. So,
do you have any preference in terms of the type of stents, brand of stent, and depends on the location and bifurcation intervention to stent strategy?
So in all fairness, the latest iterations of the stents that we currently use, whether you're looking at zotorolamus or everolimus or what have you, the technologies have very similar event rates, and they're all pretty much deliverable and so on. They're very different than when you're looking at other technologies like the biodegradable, absorbs and so on. I think something that's in the pipeline that we're still getting more data on is the bioadapter or the uncaging technology, which is still considered a drug-eluting stent with, uncaging of some of its struts that allow it to conform and perhaps restore vascular function. But we're going to need longer-term outcomes for those. But the preliminary results are pretty encouraging, actually.
I believe that you mentioned you presented that in CRT, correct? Some of your data on CRT, I think, was proximality. Maybe I'm not remembering correctly. Can you elaborate on that a little bit? Because I don't think it's available in the United States.
No, it's not. So this is a stent that actually, it is a metallic stent at the end of the day, but around 6 months, there's some uncaging that starts to happen at the level of the struts. And so you actually end up getting better lumen area over time. And compared with your conventional drug-eluting stents, you actually have better lumen gain. And some of the data that they looked at from CT, it was just presented, and at EuroPCR, I believe, and intracoronary imaging, you do see this systolic and diastolic vascular function movement of the vessel is restored to a large degree compared with drug-eluting stents. And they believe that that's why the outcomes, so when they looked at LADs, when they looked at some of the complex lesions that they actually did, they were non-inferior, but they were actually also superior to the conventional drug-eluting stents. But again, the outcomes were 1 year to 2 years. We don't really have long-term outcomes. We really haven't seen it in large trials that are looking at complex disease. Of course, they just did some sub-analysis in diabetics or CTOs and so on, but it was just sub-analyses of the recruited patients. But I think it is promising, but we certainly need long-term data before it becomes mainstream.
For the US audience who is not familiar with the technology, what do you call that technology? And are there one company making it, many companies?
So for now, as far as I know, it's called Elixir is the company, and the stent is the bioadapter stent, Dynamics bioadapter stent. And they have a very wide range that, very similar to drug-eluting stents and very long ones. And we've implanted it in acute coronary syndromes and STEMIs and in chronic coronary syndromes and in LADs and circs and so on. So they add implantation at the index procedure. They do behave very much like a drug-eluting stent. And we've done all of them because we're part of a registry for it. We've done all of them with intracoronary imaging to just make sure that we have appropriate sizing and apposition and so on. And our results have been actually very good.
Excellent. So let's change gear. We mentioned that newly graduate, they get excited about bifurcation stenting. You aware that in the United States in real practice, day-to-day practice, average interventionalist does 50, maybe 70 cases a year intervention. So they stay away from the complicated one like bifurcation. You're part of the Bifurcation Club. You help running it. There's webinars. Talk us about the Bifurcation Club. How can an audience can be maybe learn from that? And is there a way for people to watch some series or webinars?
Yeah, so the SCI, Society of Cardiovascular Angiography and Interventions, have very regular Bifurcation Club webinars where they show cases, and sometimes it's calcified lesions, sometimes it's left main lesions, sometimes it's intracoronary imaging and so on. In the Middle East, we have a Middle East Bifurcation Club as well, and we're actually collaborating with SCI in our webinars. We have another one coming up in September. We've had 2 already this year. And I think a lot of the discussion is interesting because you start to learn that there are different approaches and there are different ways to dissect these PCIs. But I think, and then there are like all these references and videos and animations that actually go step by step and show you how to do the procedures. I think in practice, what makes sense for operators who are, fresh graduates is there's no harm in pairing up with somebody else. Having a second pair of hands and a second head there with you helps because it's not just going through the motions and the steps, but it's, somebody who's there that can troubleshoot and can help you when you are unable to recross, for example, or you recross but you're unable to deliver a balloon to the side branch now. And so something like that. And I strongly advise that if the volume is about 50 a year, then early career operators really should be pairing up, and it'll give them the experience that they need.
During ESC, during ACC, during also SCI and others, there are always talks about it, but I don't think it's as thorough as the webinar. I watched the webinars. It's very informative. So I really recommend for everybody to, at their own time, to watch it. A different conversation, not related to bifurcation. You've been an advocate for women in interventional cardiology. And personally, my program director at Brown was Dr. Dawn Abbott. She's a phenomenal operator. She's a mentor. And I've worked with many, many female interventionists who are super talented. But as you may be aware of it, even in the United States and maybe other places, our general cardiology fellows, female general cardiology fellows, are running away from interventional. What's your recommendation? What's the obstacle? How do you solve that? Is it really worth to do this intervention? What's your recommendation with an insight or future graduates?
I mean, one thing is that there's this impression that the lifestyle is difficult for women who want families and so on. But we have to remember that, women in the field of medicine go into OBGYN, and they're called at, ungodly hours as well. They're called at 2 and 3 a.m. for deliveries and so on. So I don't think it's a matter of lifestyle when it comes to women. The radiation exposure remains a myth that we have to keep reminding folks that there are ways to mitigate and there are ways to address it, not just with the lead aprons. Right now, we're all talking about, core strength, for men and women, really. You really do need to work on your core strength and exercises that, strengthen the lower back and so on to be able to get into the lead. But all these new technologies that Rampart and other systems that really help with radiation protection. And so women who are thinking of getting pregnant or who are pregnant are still able to go to the lab lab if they so choose. So I think the one main issue was the radiation and radiation exposure and what can be done. And the other part of it is really creating an environment where we recognize that women can be helpful in a field of interventional cardiology, but we do have to give them a plan. So when they're 8 and 9 months pregnant, it may be very difficult to go into the lab and be wearing lead for long peripheral procedures, that are 2-3 hour long, or EP procedures. So that's where, we can say, fine, work on a little bit of research at this time and slow down or cut down the number of hours or cases that are being done. So I think we can tailor it, particularly because we do it anyway for other reasons. We just seem to shy away from it when it comes to pregnancy. But, if your colleague, man or woman, has a spine issue, we'll all jump in and say, okay, take some time off from the lab and go sort out your spine issues and come back and we'll be there for you. Or slow down or cut down the hours that you're standing on your feet while you're addressing it. And so I think we need to be looking at women operators that way too, who choose to get pregnant. And I just think we need to be having these conversations, and I'm glad you brought it up, Sameh, because that people need to just have these conversations openly and frankly. And they just need to hear it. Particularly young, those who are in students, early career, fellows. And I learned that shadowing works best. I can sit and preach or talk to a woman or a man about their career or what it's like to be an interventional cardiologist. But what I've started doing in recent years is telling them, hey, why don't you come and spend some time with us in the lab? Come and spend a week or a month and really see what it's like to be an interventional cardiologist. Get a feel for it. And some of them will change their mind and say, no, it's not for me. I'm just not interested in this. I want something more cerebral. And then there are people who will just fall in love with it. And, it's going to seduce them. They'll be like, no, I'm committed. This is what I want. So career shadowing really, really works well, I think, for interventional cardiology for men and women.
I love that idea. And also, can you comment about the mentorship programs that I think you're part of and others, both in SCI and ACC and other society, how useful that is, and what's the way for a future graduate if they want to, connect with someone and pioneer in interventional cardiology like yourself and other very talented female interventionists. What's the pathway if they don't have someone in their program?
Super. So, one way is to look up societies and, as you mentioned, SCI, ACC, the European Society, Women as One with Roxana Mehran, they all have some kind of mentorship programs. One thing to understand is that your mentor doesn't have to be a woman just because you're a woman. It can also be a man. If you're a man, you can have a woman mentor. So it's not really gender specific. And the dynamics, it's a two-way street and no two relationships are the same. I have different mentees and they all want something different. Somebody wants help with life, work-life balance. Somebody else wants push into research. Somebody wants to learn more skills in the cath lab. And so you just have to gauge what your mentee needs from you. And then you direct them, you put them in the right direction, hook them up with the right people, and you start serving as a mentor and a sponsor for these people if possible. And these mentorship dynamics change with time. So as your mentee gains experience and starts to grow in their own career, it becomes a lot more of a friendship and it takes a very different shape, and they will still come to you for advice, but very different. So when you're, I look at myself, I had mentors when I was still trying to apply to interventional cardiology. And now when I'm a director of a cath lab, it's the same mentors, but I resort to them and my questions are very different. And what I need, the help, the kind of guidance that I need from them is very different. That help me, just weigh in on leadership and that kind of thing, more administrative perhaps. But it is a relationship that continues throughout, but changes over time to meet your needs.
So such an amazing insight. I hope all our audience get inspired by everything you've been, contributing to these societies and really the field of cardiology and interventional cardiology. And I just want to thank you so much. I know it's Saturday and it's your day off, and I want to take longer than your time. I want to really thank you for joining us today, and hopefully we can have you in a future episode of BackTable. Any last comment to the audience?
I just really appreciate the invitation and thank you for having me and hope to see you in person.
Likewise. For our audience, thank you so much for joining us today on another episode of BackTable Cardiology Show. I'm looking forward to having you all in the next episode.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hadi Lisha
and Sameh Sayfo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.